Okay, can you see my title slide, Data Science, the View from Biomedicine?
Yes.
Good. All right. So actually, Jean gave you a nice overview of one aspect of biomedical data analysis. And I'm going to take you in a slightly different direction and focus less on the bio side of biomedicine and a bit more on the medicine side of biomedicine. I wanted to start with just a bit of a context around how medicine is done these days. And basically the starting point for medical decisions is grounded in evidence. And evidence in turn is largely derived through the process of randomized controlled trials. And of course, randomized controlled trials follow the scientific method and are really, really critical in our understanding of the effectiveness of particular interventions. But by design, they are limited. In order to follow the scientific method and really have a very controlled study where there's one or a manageable number of variables that are manipulated in order to understand the effect that's under study, they define very specific inclusion and exclusion criteria. And typically, Jean also mentioned this, typically the studies involve relatively small numbers of people. And so it's quite common that a patient for whom a clinician needs to make a decision really doesn't satisfy any of the evidence that's available in relation to treatment options for their situation. And clinicians are often faced with this sort of question of, do the results of a study that's been published in the literature apply to my patient? What is the kind of best evidence or best advice I can look to for my specific patient? And if my patient mostly, but not completely, satisfies the inclusion criteria or the exclusion or, has an exclusion condition, should I apply those results to my patient? And so here's a little example of a particular study which only studied men, and that's very, very common, by the way, for lots of reasons. I can give another talk about, and they specifically studied healthy weight people, so people within 20% of an ideal weight. And so, real question is if this woman over here walks into the doctor's office, what can the doctor infer about the result of this study for this particular patient? She's female, not a male, and she's not within 20% of her ideal weight. So what do we do? I'm going to argue that we need to look into electronic health records, and we need to leverage the digital data that is being collected increasingly in medicine in order for us to derive analysis and information that can support that sort of decision making. And so the starting point for this is electronic health records, which record a vast array of different kinds of data, sometimes including that genomic data and things like microbiome and blood biomarkers and these sorts of things, but also including lots of other kinds of data, including vital signs, images, EEG, ECG, of course, things like prescription information, like what was actually done to the patient, and any side effects or consequences of treatment. There's also a heap of patient-derived data that we can talk about. Biosensors, wearables, probably a number of you are wearing a Fitbit or an Apple Watch, something that's tracking basic information about related to your health, that's relevant to your health. Also things like digital diaries and even speech. Speech is increasingly being looked at, particularly for cognitive function. So we end up with this massive quantity of real-world clinical data that we can leverage to help us really answer the questions we might have about how to treat patients. And a lot of the work that's been done in this context has really been at the level of coded data. So this is data that's been transformed into numbers, right, that are easy to work with and that have standardized definitions associated with them. The most prevalent coding system that's used for this sort of research or analysis is the ICD, the International Classification of Disease. But we also have that full range of more structured data that's available to us from things like pathology analysis and the images and so forth. We also have a vast quantity of clinical unstructured data, the notes, the discharge summaries, the radiology reports, and the studies that are analyzed by experts and captured their findings in natural language. And so a lot of my work, which I won't tell you about in any detail, but a lot of my work is focused on taking that unstructured data and transforming it into more structured data or information that we can leverage for modeling. But the basic idea is that we want to characterize patients in terms of mathematical representation of their signs and symptoms and their characteristics. And we can put that on a timeline that's associated with their particular journey as a patient. And really, this is sort of a high-level schema of what I'm talking about here, mapping conditions, diseases, and symptoms that a patient might have, drugs that they might be treated with, various measurements that we take, and procedures or interventions that we apply to them onto a timeline. And then leveraging this to across the population of patients that we have captured in an electronic record system to really start to analyze the relationship statistically between these different patterns in the data and in particular clinical questions. And we can think back to the woman that I introduced you to at the beginning. Let's call her Miss Orange. Miss Orange is a patient in a sea of patients for whom we have data available. And what we might want to try to do is map Miss Orange based on her specific profile into the population that we have. And by clustering patients according to some notion of similarity, we can start to then examine the data that we have for those different subgroups within the data set in order to help us get a grip on what might work for Miss Orange, or what her trajectory is likely to be under different treatment protocols. So really, in a nutshell, we're trying to use the real world data that we're already capturing in the course of clinical care to produce evidence. And this idea of patients like mine is really, dynamic cohort construction based on clinical characteristics. And then once we have that, we need to think about, what are the tools we have available to us for identifying appropriate controls within that data set for comparative analysis. It's not an easy problem. And then searching for outcomes of interest. And we can, apply the basic tools of data science to count things, to estimate things, and to predict things with that data and that kind of structure around the data as the context in which we do that, and Mrs. Orange in focus. So when we talk about big data, we often hear people talk about the 4 V's: volume, variety, velocity, and veracity. And all of those clearly apply in the context of our electronic health record data sets. But it raises a whole number of other issues specifically in this context, and I'm sure other contexts, but they definitely can be seen in the medical context, where we have massive complexity, all these different types of data. So, Jean took us on a journey right down to one specific layer of biological representation. Here we're talking about, very, very different types of data, not just different scales, but different types of data, radically different.
Karin,
Karin,
just 1 minute. Yeah.
Yep, no worries, I'm almost done. So we have to worry about the quality of the data, the causality that may exist within the data, confounding, and of course, counterfactual reasoning. What might have happened to a group of patients if we had made a different decision in their treatment? So leveraging all of this evidence allows us to really think about how we can build on the population level information that we have to support the individual treatment decisions for individual patients, and building models of real people that exist in the real world, not just under controlled conditions, but in real world conditions. And ultimately, what we'd like to see happen, and something I'm hoping to work towards, is a global learning health system where we basically leverage the practice of medicine that's captured in our electronic health record systems to inform the treatment of patients. And then as we treat patients, we collect more data and we get this nice kind of virtuous circle. And to do all of this requires many different aspects of data science, including data integration and data analysis, and effectively formal representation of our inferences. So I'll just leave you with this. Data is the new oil. AI, I think, is the engine of innovation and fueled with data. And it's really important that we take advantage of these data sets and these methods in order to allow us to apply it in the context of healthcare. Thank you.